Hi, welcome to Detours Understanding Acquired Brain Injury. And today I want to talk to you about diagnosis of brain injury and a little bit about, for example, the DSM-5, the DSM-V-TR. Now, what is that? DSM-5 is a diagnostic tool. It's a text that is used by usually psychiatrists, but other medical professionals too, here in the United States specifically, to help with the diagnosis of oftentimes mental illness, but many other neurological conditions as well. And the reason it was generated was because there really, here in the United States, there are different concerns that we have related to insurance and how things are coded for. Coding is, I've always called it a dark art because it is a complex way of recording for billing and things like that with the insurance company, and they want a lot of specificity. The thing is, when it comes to trying to use tools like this for coding, it requires quite a long time. There's specific coursework for coding. But what I'm going to talk specifically is about some of the changes with diagnosis using the DSM-5 and the TR text revision. TR means text revision. So that means there were some changes made since the DSM-5 came out in 2013. Obviously, since it's 5, it means there were others, and there were some text revisions in there. So it's been around for a while. Most of the rest of the world uses, America being different, of course, most of the rest of the world uses what's called the International Code of Diseases, and most American physicians do use the International Code of Diseases, the ICD-10, and we're waiting for the ICD-11 to come out. But, and the psychiatrists and a lot of neurologists and others do use also the DSM-5 text revision, TR. So I will be calling DSM-V-TR. All right, so when it comes to neurological problems, psych problems, specifically neurological, like head injuries, things like that, in the DSM-4 and the DSM-IV-TR, actually in the DSM-3 as well, back in the 1980s, I think 83 was when the TR came out, DSM-III-TR came out, they describe brain injury as simply dementia. And then you would pick subtypes within that. But it was described as quite simply as dementia. And the problem with that, obviously, is that with popular media's portrayal of dementia as being grandma with Alzheimer's, and quite simply it was that and that was that. And so when you would give a client a diagnosis with dementia, that led to confusion. Not only with consumers, but insurance companies who weren't really sure the coders and stuff understood, but a lot of the people who approve things and would help for payment, that could lead to some confusion and resistance also. And since the insurance companies were the ones who were paying a majority of the bill, and they didn't necessarily have medical education, I know that's another problem, that definitely could lead to delays in care and treatment for patients. So, in the DSM-5, when that came out in 2013, there was a shift. And instead, we moved to what we call major and mild neurocognitive disorders to describe brain injury, acquired brain injury. So instead, you give a patient who has, for example, traumatic brain injury, but others acquired brain injuries, a diagnosis of either mild or major neurocognitive, self-explanatory. It is based on neurology, based on their neurons. Cognitive, meaning thinking, disorders. So you would first start calling it either major or mild neurocognitive disorders. So that would be the first thing, that would be the stem, what you would call it. So a patient either has major or mild neurocognitive disorders. And then you would add to there based on what they have. So let's take a look at what the criteria is to diagnose somebody with a major or mild neurocognitive disorder. First, They have to have, and I'm taking this directly from the DSM-V-TR, they have to have a significant, for either major or mild, a major neurocognitive disorder. Patient to be diagnosed with major neurocognitive disorder has to have a major, significant cognitive decline from a previous level of performance in one or more cognitive domains. So, complex attention, executive function, we've talked about that on the channel before, learning, memory, language, perceptual motor, or social cognition. So social understanding as well. And this would have to be based on, one of these things would have to be based on these two things: either a concern by the individual, knowledgeable informant, so family members, other things like that, or if they're in a nursing home or whatever, would have to report this kind of thing, or a clinician says you have a problem with either complex attention, executive functions, learning, memory, language, perceptual motors, skills, or social cognition. So either the patient, somebody knowledgeable in their life, or the clinician first. Second, substantial impairment in cognitive performance, preferably documented by standard neuropsychological testing. This is important. This is a change. Or, in its absence, another qualified clinical assessment. So some kind of tool to help detect that. So they would prefer that it be verified by neuropsychological assessment. We talked about neuropsychology before. Or, if we don't have that, some office-based standardized test that's given to the patient. Another qualified clinical assessment, some tool that you have to back this up. So those two things have to be met: concern from family, friends, the patient, clinician, and either neuropsychological assessment or that they have a standardized office assessment. Okay. Next, within a major neurocognitive disorder, the cognitive deficits, and this is important, interfere with everyday activities. This is the difference, significant difference between major and mild. They interfere with everyday activities. So, at the minimum, the person would require paying bills, would have problems paying bills without help. They would have trouble with managing their own medications or other things. They'll need help with these things. If they need help with these things, that's kind of says, all right, this is probably a major problem. See, the cognitive deficits do not occur within context of delirium. So that's not like after a seizure or after, while they're coming out of a coma or something. This has to be all the time, pretty much. And they need help. And they've reported it, all right? And cognitive deficits are not explained by other mental disorders like depression, schizophrenia, any of the others. So those are the things. And then they can be coming from a variety of other conditions. So etiology, cause, can be Alzheimer's, frontotemporal dementia, Lewy body disease, vascular disease, traumatic brain injury, substance abuse, HIV, Parkinson's disease, Huntington's. Another medical condition, an infection or something, can cause the damage. Sepsis, we've talked about that, can cause this kind of thing. But what's significant between major and minor is that it interferes with everyday activities to the point that you need help in doing these everyday activities. It's not caused by another condition that you need like this kind of help, and it's concern of the individual, family members, other people around them, or the clinician. These mark out major. Minor, on the other hand, let me get this over to the minor. I just want to make sure. Mild neurocognitive disorder. Mild neurocognitive, evidence of modest decline from a previous level of function in one or more cognitive domains. This is mild neurocognitive disorder. Complex attention, just like major, mild. Executive function, learning, memory, language, perceptual motor, social cognition. So it is a modest cognitive decline. And it comes from either a concern of the individual, comes from knowledgeable informant, or clinician, that there has been a mild decline, cognitive function. And modest impairment in cognitive performance, preferably documented by standardized neuropsychological assessment, same as before. And in its absence, another qualified clinical assessment. Because sometimes it just doesn't, we can't afford to send them for assessment, but it's important to know that this is preferable. Also, this is important. Here's the dividing line. These deficits do not interfere with the capacity for independence in everyday activities. In other words, they could do complex instrumental activities of daily living, like paying their own bills, managing medications, but they do need greater help. As in, they have to use compensatory strategies. They do need maybe not a person to do it for them, but they need like the little pill boxes, or they need extra software, they need like all kinds of notes and other things like that. The difference is whether you need somebody to help you do this, or whether you need intervention, or you just can't do it at all, versus all kinds of extra strategies and little things like that. That being the dividing line there. Greater effort, compensatory strategies. Also, the cognitive deficits do not occur exclusively in the context of delirium. This is the same as for major neurocognitive disorder. These deficits cannot occur while you're delirious due to drugs, medicine, coming out of a coma, whatever. These have to be everyday kind of problems. Also, the cognitive deficits are not better explained by another mental disorder. So again, the big dividing line is whether you need somebody else to do it for you, somebody else's help, because you really can't do it on your own. That's the big dividing between major and mild neurocognitive disorder. Now let's take a look at some of the specific then subtypes. So different disorders cause different problems. So let's take a look at, pardon me while I change the pages here, but we'll look at major and mild due to traumatic brain injury. And we'll look at like vascular as well. So pardon me, but I think it's important to like look at, all right, so major or mild vascular neurocognitive disorder. So the criteria already met for major or mild neurocognitive disorder. So patient is concerned, family member is concerned, or like nurse or whatever, someone with a family member, and clinician, and or somebody else with them, and they've gotten neuropsychological testing or standardized testing. So that shows that they're having these problems, and it's either enough to interfere with daily living with those instrumental activities, and somebody needs to help them, or that they need a lot of compensatory strategies. It's not due to delirium, and it's not due to it's not better explained by some other mental health disorder. It doesn't mean they don't have them. It just means that that's not a better explanation, that they're having deep depression, anxiety, something like that. Okay, so the criteria are met for either major or mild neurocognitive disorder first. Second, clinical features are consistent with a vascular etiology cause, so supported by either the onset of cognitive deficits is temporally related, related to one or more cerebrovascular events. They've had an aneurysm or stroke, ischemic event. 2, evidence for decline is prominent in complex attention or frontal executive dysfunction, which is typical with that. There's evidence for the presence of cerebrovascular disease from history, physical examination, and neuroimaging, and is considered sufficient to account for neurocognitive deficits. So what they're saying is, we know you've had this disease. We've seen it perhaps in imaging, through physical, and it does account for the symptoms you're seeing. Also, the probable vascular neurocognitive disorder is given. It's given as probable instead of possible when you're looking at major vascular neurocognitive disorder, because what we're saying is, yeah, we're really, really sure. You can never say 100%, but you can say really sure when we're seeing major neurocognitive disorder. We're saying, yeah, we're really sure this is what's causing it. Okay, so clinical criteria are supported by neuroimaging. So if you see this on the scanner, we're virtually certain that this is what causes it. If one or more of the following are seen: significant parenchymal injury. So if we see damage to the white matter, to the tissue itself, brain shrinkage, white matter inclusion, we talked about that also. And so we could say, hey, yeah, this kind of damage is consistent. If we've seen white matter inclusion, if we've seen inclusion bodies, things like that on the MRIs, then we know, yes, this is definitely highly probable due to the vascular problems. Okay, so neuroimaging supports. That is one of the things that makes it probable vascular neurocognitive disorder. Neurocognitive symptoms are related to one or more documented, so records support it. Both clinical and genetic evidence supports cerebrovascular disease. Otherwise, we're saying possible vascular neurocognitive disorder because we may not have the imaging or other records to support it. Okay? Let's go to major or mild neurocognitive disorder due to traumatic brain injury. And the criteria are met, again, for major or mild neurocognitive disorders. You know the litany here about the person being concerned, about family being concerned, or like a nurse that works with them, or the clinician is concerned first. Second, it either interferes with activities of daily living, those paying bills or sorting your medications or whatever, or that you need a lot of supports for it, even if somebody else doesn't do it for you, and that's more for the mild, and it's not as significant a cognitive skill decline. And it's in those areas, complex attention, the planning, the executive skills, social cognition, emotional, those domains that make it either mild or major neurocognitive disorders. Also, now specific to traumatic brain injury, we're also looking for loss of consciousness, post-traumatic amnesia. So this is after. How long does it take for you to be able to hold on to new memories instead of asking the same questions or not being sure what happened? That period where you are not able to make new memories, and that affects it too. Disorientation and confusion as to what's going on versus being totally unconscious or being just dazed, and that's yet another one or more of these following. Neurological signs, either neuroimaging, new onset of seizures, worsening of pre-existing seizures, visual field cuts, anosmia, so not being able to recognize smell, hemiparesis, so half your body's paralyzed. These things are criteria that are meaning, and as well as skull fracture, things like that. These characteristics are associated with major and probable traumatic brain injury. So then you would further specify with or without behavioral disturbance, because with oftentimes you would be looking for whether the person's having behavioral problems, acting out, aggression, irritability, those kind of things, and you would subcode that depending on how they're acting. What differentiates some of these, there's still arguments, and I've mentioned this before, for severity. Mild traumatic brain injury, loss of consciousness for less than 30 minutes. Moderate, 30 minutes to 24 hours. Severe, more than 24 hours. This is a current, me, I'm somewhere I'm in the moderate range based on that. Although could have been as long as a day and a half. So I'm somewhere between moderate and severe. Post-traumatic amnesia, less than 24 hours, 24 hours to 7 days for moderate, and more than 7 days for severe. That would be me. And then disorientation and confusion at the initial assessment by EMS or at the hospital. If you're disoriented and confused and stuff, for 13 minutes to 30 minutes, mild. Moderate, 9 to 12. And if it's 3 to 8, I apologize. Yes, wrong. With the GCS, where it ranks 2, that needs to be included also. So 15 to 13, but not below 13 at 30 minutes. 9 to 12 GCS, moderate. And 3 to 8, severe. And that's yet another ranking that could be used. So it's complex. They still haven't agreed on what kind of level of injury you need to be ranked, mild, moderate, and severe. So we're looking more at symptoms. And this is one of the places where major mild neurocognitive disorder can apply. And, there's the difference between, there's for medication. Certain medications can cause neurocognitive disorder, major versus mild. Again, it's the same thing. Criteria are met for either major or mild neurocognitive disorders. The neurocognitive disorders do not occur during coma or delirium. The involved substance or medication and duration and extent of use are capable of producing the impairment. So it has to be something that actually would cause based on research. The temporal cause of neurocognitive deficits is consistent with the timing that the medication use and abstinence, non-use, and the deficits are stable or improve after a period of abstinence of the substance or medication. The neurocognitive disorder is not attributable to another medication and is not better explained by another mental disorder. And again, then the severity determines whether it's major or mild, whether you need a person to support you for those certain essential functions. So, and then there's also further specifications. Are these neurocognitive impairments persistent? Cases like with brain injury and such, yes, they would be. But if it's a mild neurocognitive, maybe it isn't. So there's a lot of like things that you define, don't define within major and mild neurocognitive disorders, and it gives you that flexibility. But of course, then you have to ask certain questions after that. And a good clinician will record what's happened, will record the case history, will record specific symptoms and complaints, and will record the patient assessment, things like that. Any neuroimaging will include that kind of information as well, rather than just put a diagnosis. And it leads anybody to the kind of question like, why do we diagnose in the first place? Well, one of the reasons why is to make it easier for a clinician to communicate with clinician. Because writing down 5,000 words to describe something that in a couple, maybe in about 25, 50 words can be communicated. It also helps organize the way you think about something. Describing something as mild or major neurocognitive disorder tells you a lot about what it is, tells you cause, etiology, it tells you what the likely prognosis is, it tells you the kind of help they'll need. It helps you to communicate with the patient more effectively and tells the patient like what kind of things to expect if you teach it right. That's key. It also is necessary for continuing medical treatment. The insurance companies need this, want this, because it lets them to organize how payments, it helps them decide like from what areas they'll need to draw funds, and it will help them know where, like for government funds, from where to reach, because insurance companies alone often don't have the appropriate funding, especially for traumatic brain injury or else, but to direct and to draw resources from. Same thing for physicians or others who would diagnose. And it's more than just your MD or DO who can diagnose. Clinical psychologists do, neuropsychologists are trained in diagnosis and would put a diagnosis down. Now, the domain for which they diagnose is much narrower, but they also have diagnostic privileges. And therapists do too. PTs, OTs, again, their range of what they diagnose is much smaller, but they also have the right to diagnose. And finally, the reason diagnosis is important is for the sake of the patient and the family. Many times, patients, family members wonder, what the heck is going on? And, why is Mary or Jimmy or whomever acting the way they are? Why do they have the problems they do? And it helps to validate some of the problems and some of the concerns. To me, I think this is one of the best things that a physician or whomever is doing the diagnosis can do for a patient, is to help them better understand It's important to remember you are not your diagnosis, okay? You are not your diagnosis, but it does help you kind of tame it, bring the chaos, bring order out of chaos, as it were, and help say, all right, this is what, I've got. This is what is going on. This is probable cause, probable. And this is probable treatments today. This is probable long-term outcome, which is also important. It gives you a little more control as a patient and helps you know things. Is it perfect? Not at all. Not even a little bit. But it does tame the noise and does bring things together. It helps you meet other people who share many of these things in common. It does do more good in the end, even if there are problems, even if they're not perfect. And especially in mental health and psychiatry, where diagnosis is really kind of a sticky thing, because we don't know causes completely yet. We're still learning the brain. It's still a big mystery in a lot of ways. We are getting better. Oftentimes when a diagnosis is nailed down, when we really know what causes something, it slips out of the fingers of the psychiatric practitioners, out of the hands of the psychiatrist, and it moves next door into neurology. Seizures were long thought to be a mental health problem. Now we know they're a neurological thing due to scarring and damage to certain areas of the brain, kindling, all that good stuff. It's not mental health, it's neurology now. And so the psychiatrists don't quite get the nods, the kudos, and the back pats that they deserve. And the fact is they work with something much harder, much more slippery, the mind. And so it is difficult. It is difficult to be in psychiatry, brain injury, even neurology. That's still kind of a hard discipline because there's still things we don't really understand the brain well yet. We're getting there. It's a long, hard slog. And so I say kudos to the psychs and, other practitioners who deal with something hard. All right. So it's a little look at major and mild neurocognitive disorders. And we'll get back to that. And a look at why diagnosis is important. It's important to understand major and mild neurocognitive disorders and their use. To understand the difference being whether you need help or not is the key, whether you need help doing basic functions. That's really the essential thing. Why diagnosis is important, to organize, to bring order out of chaos. Thirdly, to understand that, psychiatric diagnoses are tough, and to appreciate those who try to make a difficult thing just a little easier. Okay? Hope you enjoyed it. Hope you found it useful and instructive. Talk to you in the next episode. Bye. Please click like and subscribe.